Thank you for the committee members to invite me for this congress. The title of my study is Cross-Cultural Adaptation and Measurement Properties of the Malay Shoulder Pain and Disability Index. These are the content of my presentation. Shoulder pain is a common musculoskeletal disorder with a lifetime prevalence of 7 to 67%. 67% depends on the region and age. In Malaysia, it was the third musculoskeletal disorder causing disability and fourth in the total cost of workers' compensation claim per body part. Studies done in 2015 reported that among office workers in Malaysia, about 53% had shoulder pain. And the overall prevalence of chronic shoulder pain increasing with age and peak after the age of 50. As Malaysian is an aging population with 7.3% of our population aged more than 65, many studies ongoing on the MSK-related disability and problem, including shoulder. One of the most important research tools to monitor disease progress and treatment efficacy is by the use of patient-reported outcome measures or PROMs. PROM for shoulder consists of 3 types. By which it consists of upper extremity region specific, for example, disability of arm, shoulder and hand questionnaire or DASH questionnaire. You have shoulder specific, for example, shoulder pain and disability index or constant Molly score, and also disease specific, for example, Western Ontario rotator cuff index and Oxford shoulder instability index score. Which one to use is actually depends on the intention of the research or condition. For example, American Shoulder and Elbow Surgeon Questionnaire was used to assess patients with diagnosis of rotator cuff disease, glenohumeral arthritis, and also to monitor disease progress after shoulder arthroplasty. There are at least 50 patient-reported outcome measures for shoulder function, with the most frequently referred and used include the Shoulder Pain and Disability Index Questionnaire and Constant Molly score. Systematic review conclude that no single shoulder assessment tool was superior to the other, but recommends SPADI as a tool for clinical and research use. SPADI, originally in English, self-administered, developed by Roach et al. In 1991 to measure pain and disability in patients with shoulder joint disorder, which is non-specific. It is a very short and easily understood questionnaire applicable in various shoulder pathology and has established good validity and reliability. It has been cross-culturally adapted into multiple languages, including Spanish, Chinese, Thai, Marathi, Brazilian, Greek, Italian, and so on. So, what is cross-cultural adaptation? Is actually a process of considering any differences in an instrument between the source and the target culture so as to maintain equivalence in both culture. The aim is to achieve semantic and idiomatic equivalence between the original and adapted version, which is different from a single or simple word-for-word translation. Malaysia is a multiracial country with Malay language is considered as a national language. Ministry of Education reported that the English proficiency in our nation ranged from low to moderate. Furthermore, Malay language was widely recognized in the Southeast Asian countries such as Brunei, Indonesia, and Singapore. Unfortunately, we don't have any shoulder questionnaire, even spine questionnaire, which was translated into Malay language. Thus, this research was conducted with the following aim. 1, to cross-culturally adapt the shoulder pain and disability index from English to Malay. And 2nd, to evaluate the measurement properties of the Malay version among Malay speakers with shoulder pain and measure the properties evaluation based on Cosmin guideline. The methodology, the study was divided into 3 phases. Phase 1 was done according to the consensus-based standard for the selection of health measurement instrument or Cosmin guideline. SPADI was chosen because of less burden and easy interpretation compared to other questionnaires. Phase 2 was done according to the guideline by Britton et al. A forward and backward translation process, by which in phase 2 we perform content validity analysis, by which the expert from various related disciplines, for example, orthopedic, sports medicine, family medicine, physiotherapists, and expert in translational process were included and give feedback. Subsequently, we also perform phase validity analysis, by which we pre-tested the translated questionnaire and get feedback on the questionnaire from the lay person before we produce the final version, which is the Malay Shoulder Pain and Disability Index, or the short form is MSPADI. The third phase was a validity and reliability study of the M-SPADI, by which the study was done in University Malaya Medical Center, Kuala Lumpur, Malaysia, and the sample size was based on the participant to item ratio of at least 1/5. Since study has 13 questions, so we need a minimum of 65 participants, but for our study, we included 260 participants. These here are the protocol by which we use universal sampling. Patients who came to our clinic within the specific period of time were approached to answer the question. After obtaining writing informed consent, patients were assessed to stratify them into either group shoulder pain or non-shoulder pain group. For patients with shoulder pain group, further assessment on the clinical and ultrasound was performed to confirm the diagnosis. The first assessment consists of active range of motion, and all the participants required to answer two questionnaire, which is the numerical rating scale and M-SPADI questionnaire. Patients who did not receive any treatment were approached to answer the M-SPADI again by email at 7 to 14 days later to assess the reliability. For responsiveness, patients with rotator cuff pathology who received regenerative treatment was invited to answer the M-SPADI again after 3 months. The study used the numerical rating scale version of SPADI. SPADI has 13 items subdivided into 2 subscales which measure pain, 5 items, and disability, 8 items. The initial VAS or Visual Analog Score was replaced by an 11-point numerical scale where the individual score their level of pain or difficulty from 0, which means no pain or no difficulty, to 10, worst pain imaginable, so difficult it requires help. The total SPADI score is the unweighted mean of pain and disability domain score. The score range from 0, the best, to 100, the worst, with no cutoff point to indicate severity, as it was designed to measure current status and change over time. It recorded the activities limitation in the past 1 week. The numerical rating scale is an instrument for pain intensity assessment where individuals are asked to select a number from 0 to 10 that best describe their pain intensity. And for the active range of movement protocol by Dolly et al. Was followed by using universal phonometer. The range of motion that we measure include forward flexion, abduction, extension, internal rotation, and external rotation. Assessment of the measurement properties according to Cosmin guideline consists of 3 domains, which are reliability, validity, and responsiveness. Reliability is defined as a degree to which the measurement is free from measurement error, and it encompasses of internal consistency, test reliability, and measurement error. For validity is defined as a degree to which an outcome measure the contract is supposed to measure, and include content validity, construct validity with structure validity, hypothesis testing, and measurement invariant as subsets and criterion validity. The last domain is responsiveness and is defined as the ability of an outcome measures to detect change over time in the construct to be measured. Even though there are other methods to assess for assessment or reporting the questionnaire, the Cosmin is the most widespread and comprehensive tool to be used for health-related quality of life instrument for evaluative purpose. This table here provides the list of measurement analysis we did to assess the translated questionnaire validity, reliability, and responsiveness. We use SPSS and Smart PLS for analysis. These are the results. We received good response from participants, which we believe because the median time to complete the M-SPADI was about 2 minutes, and comparable to it actually comparable with previous study, by which it shows that it has a very short duration to answer the question. Due to the online survey design, there was no missing data except for test retest, where 4 participants did not complete the second M-SPADI testing. And this table here shows a descriptive statistic for participant demographic. There are several parameters showed significant difference between patients with shoulder pain and non-shoulder pain group, especially age, which were expected, because most of the patients with shoulder pain is actually at a much older age group. And we include the difference as covariates in our subsequent analysis. Some of the diagnosis that the common diagnosis was actually rotator cuff injury with and without impingement accounted for about 55% of the cases, frozen shoulder about 15%, and the rest. This table here displays the descriptive statistic of the M study, numerical rating scale, and show the range of motion between two groups at baseline. This is the result of content validity. The scale level content validity index and item content validity index for all items were more than 0.79, except for disability item 3, which was actually putting on an undershirt or jumper, which had an ICVI of 0.75. Since the score was between 0.7 to 0.79, it required amendment but not elimination. Following the content validity scoring, the item was amended by the expert committee and trialed during the pre-testing of M-SPADI, and the results showed that the amended term, which was originally undershirt or jumper, were changed to direct translation of sweater and short sleeve shirt. Next, we go to this one. It's a structural validity, which shows exploratory factor analysis, which was performed using principal component analysis with Varimax rotation. Two factors were extracted with eigenvalues more than 1, where factor 1, disability, explained about 67% of variance, and factor 2, pain, explained about 90% of variance. Items that loaded onto factor 1 were disability item 1, 2, 4, 5, and 8, while items that loaded onto factors 2 were pain item 1, 2, 3, 5, and disability item 7. Pain item 4, disability item 3, and 6 showed close loading as demonstrated in this table here. This table here shows a convergent validity, which is part of the hypothesis testing for construct validity results. Spearman correlation revealed a statistically significant, strong, and positive correlation between the numerical rating scale and M-SPADI pain subscale and M-SPADI disability subscale. The results supported our hypothesis that M-SPADI subscale and total score are strongly and positively correlated with numerical rating scale. For M-SPADI pain subscale, the disability and total score showed statistically significant negative correlation to show the active range of motion, as you can see here, with majority showed moderate correlation strength, confirming our hypothesis. This is the result of non-group validity, part of hypothesis testing as well. Generalized linear model analysis revealed that after the exclusion of age, education, and occupation as covariate, the M-SPADI pain score, disability, and total score were significantly higher in the patient with shoulder pain compared to non-shoulder pain group. The difference between the score was statistically significant with a moderate effect size. Less than 15% of participants with shoulder pain achieved the lowest or highest possible score in the pain subscale, which indicate that M-SPADI has no floor or ceiling effect. The M-SPADI and disability subscale has a good internal consistency with the Cronbach alpha of pain more than 0.91 and the Cronbach alpha for disability more than 0.94. 56 participants completed the test-retest with a mean time of 9.2 days between the first and second test, and the intra-class correlation coefficient result of the M-SPADI pain subscale, disability, and total score revealed good to excellent test-retest reliability result. For responsiveness, each of the M-SPADI component showed area on the curve of more than 0.9. 30 patients with rotator cuff tendinopathy underwent regenerative therapy were evaluated after 3 months. Numerical rating scale score of 5 and more was considered no efficacy, and less than 4 was considered efficacy. The M-SPADI able to differentiate between these two groups. As a discussion, during the expert committee review, there were 2 main issues. The first was the ability item 3, putting on an undershirt or jumper, which scored ICVI of 0.75. This item had issue with the word undershirt and jumper, by which in Malaysia we don't really use it. Thus, it required multiple amendments and a trial in the presenting M-SPADI before being accepted by the expert committee. This was a similar issue faced by the Brazilian Portuguese study, which substituted the word jumper for t-shirt. The pre-testing of M-SPADI results show no participant had issue with new item, and the subsequent decision by the expert committee and researchers was to accept the item. The second issue was ensuring the M-SPADI was accessible and generalized to all Malay-speaking individuals from various education and geographical backgrounds. This was accomplished by following the recommendation that prompts should be simple enough for a 12-year-old to understand. Some initial Malay terms were accurate translation but were complicated and not commonly used. Simpler Malay words were selected. For structural validity, the exploratory the EFA showed that M-SPIDY has a bidimensional structure with 5 items loading onto factor 1 and another 5 items loading onto factor 2. The 3 items which show cross-loading were pain item 4, disability item 3, and disability item 6, all of which were overhead activities. Even though these items show cross-loading, they all have higher loading on their predicted factors. The M-SPIDY EFA revealed that items involving overhead activities tended to load for both pain and disability, while items regarding carrying heavy objects tend to load with pain despite being categorized as disability item. Our EFA finding was similar to a study by McDermott and may suggest the respondent cannot distinguish between the pain and disability in some functional items. Other studies which has similar EFA of 2 factors with some item cross-loading were the original SPIDY, Spanish SPIDY, and Slovene SPIDY. The Chinese SPIDY reported 2 distinct factors with no cross-loading, while other studies reported a single factors up to 3 factors. Convergent validity, which is a subset of construct validity, was established by comparing M-SPIDY to NRS and comparing M-SPIDY to shoulder active range of motion. M-SPIDY had a stronger positive correlation with numerical rating scale when compared to Spanish and Chinese SPIDY. Different correlation strength could be due to the study utilized different pain scale, which were the NRS and the visual analog score. Spearman correlation proved that hypothesis that M-SPIDY subscale and total score were negatively correlated with shoulder range of motion. Previous studies also reported a negative correlation, and however, for M-SPIDY, disability subscale had the best correlation with active range of motion, whereas Telugu and Tamil SPIDY, pain subscale had the best correlation with active range of motion. Original SPIDY reported similar result for all 3 scales with moderate to strong correlation with rank. Different in the finding between M-SPIDY, Tamil SPIDY, and Telugu SPIDY could be due to the difference in the severity and duration of the shoulder disease at the time of data collection. Generalized linear model analysis revealed that after the exclusion of age, education, and occupation as core variate, the M-SPIDY pain score, disability score, and total score were significantly higher in the shoulder pain group compared to no shoulder pain group. This confirmed that M-SPIDY could discriminate between different groups, in this case, participants with and without shoulder pain. Other studies with reported non-group validity for SPIDY include Dutch SPIDY, Slovene, and Danish SPIDY. They compared high and low initial pain score, for example, in Dutch SPIDY, work absence versus no work absence for SPIDY, Slovene SPIDY, and different severities of self-reported perceived disability in the Danish SPIDY. From alpha for total score was not calculated as our EFA concluded that M-SPIDY is bidimensional. Instead, we reported Cromba alpha for each unidimensional domain, which is the pain and disability. And the result was actually more than 0.9. These results are comparable to those reported in the original SPIDY and other non-translated SPIDY. This result shows that M-SPIDY has a high internal consistency and does not have item redundancy as it did not cross the Cromba alpha of 0.95 threshold. The test retest reliability for M-SPIDY was rated good to excellent and was superior to the original SPIDY, which had moderate test retest reliability. The original SPIDY finding could be due to a small sample size of 37 males compared to us, we have about 56 or 130 participants, and a recent systematic review report that test retest reliability of SPIDY ranges from ICC of 0.85 to 0.92. A limited number of studies assess the responsiveness, especially for SPIDY. However, the comparison was difficult to perform because the majority of the studies did not include information on the treatment received by the patient. Furthermore, difference in the disease severity and disease intervention may cause variability in the responsiveness outcome. The strength of the study was its large sample size fulfilling the COSMIN guideline requirement. Moreover, the study adhered to the standard method and guidelines for all procedure. In addition, the study included non-group validity comparing participants with and without shoulder pain while excluding the effect of covariates which has not been performed before. The limitation of the study was that it was conducted near a single urban center with 75% of our participants having tertiary education, which may cause bias in the result. A multi-center study conducted in rural and urban setting with participants of different educational background could give a different result. We also noted that the mean time interval for the test-retest was 9.2 days, which was longer than the recommended 7 days. We recommend future prospective studies for the M study to examine the measurement invariance and responsiveness in multi-center studies involving rural and urban population. As a conclusion, M-SPADI has a bidimensional structure which could base content validity and establish construct validity, good internal consistency, and good to excellent test-retest reliability. It also has no flaw or ceiling effects. Overall, the M-SPADI is a reliable and valid tool to assess pain and disability in Malay-speaking individuals with shoulder pain and in clinical research setting. Now, actually, we are in our process of translating a spine questionnaire, which is a back questionnaire, which is still in the content validity stage. With that, thank you. Do I have any question from the